Good morning, everyone. Welcome to our May AIDS Clinical Conference. I'm delighted to introduce our speaker today. Many of you know Maria Corcorran. She's a longtime member of the ECHO community and works with David Spock on the hepatitis national curriculum. She trained here at University of Washington in medical school, residency, and fellowship. And she's a longtime advocate for persons with viral hepatitis, starting her work even before medical school, working for the Hepatitis Education Project, and now is the board president of that organization. And she is also the medical director for our status neutral low barrier clinics that are really working with funding through End the HIV Epidemic, and is an advocate for sexual health as well, and is the dynamo in that she's an educator, a fantastic clinician, and a researcher. So I'm really excited to hear about her talk today. And so thank you, Maria.
Sharisha, for that very kind introduction. It's a pleasure to be here with you guys this morning. And I am going to be talking about management and prevention of hepatitis B and C in persons with HIV. So a lot to get through. I don't have any disclosures. The objectives for my talk today will be to outline key HBV prevention strategies in people living with and at risk for HIV, to review hepatitis B treatment recommendations for people living with HIV, discuss Hep C prevention messages and strategies for people living with and without HIV, and then to review hepatitis C treatment recommendations for people living with HIV. So let's get started. So globally, an estimated 8 to 10% of people with HIV have chronic hepatitis B infection, and most individuals acquire Hep B through perinatal transmission. That's the most common risk factor globally. Here in the United States, the prevalence of chronic hepatitis B is less in people without HIV, estimated to be about 0.3 to 0.7% in the general population. But the prevalence is higher amongst people living with HIV, estimated to be about 5 to 10%. And the most common risk factors here in the US across the population include multiple sexual partners and injection drug use. Then the figure you're seeing here on the right of your screen shows data from the HIV outpatient study during the years of 1996 through 2007. And investigators have consistently found HBV prevalence rates to be in the 8th percentile range among persons with HIV, with an 8.4% prevalence across those years of 1996 to 2007. In this study, they reported that the highest risk factor for chronic HBV, or that the rates of HBV were highest among men who have sex with men living with HIV. However, I will point out that these data were collected largely before the opioid epidemic, and newer data from the CDC reports that injection drug use is the largest risk factor for HBV in the general population. And that's people acquiring HBV newly here in the United States. People with HIV are more likely than those without HIV to develop chronic HBV infection, meaning that they're less likely to clear HBV on their own. And co-infection can lead to accelerated progression of liver disease, including increased risk for HCC or liver cancer, liver-related mortality, and all-cause mortality. And then hepatitis B remains a major contributor to end-stage liver disease and liver-related death, even in the modern ART era. And data on this figure on the right are from 25,486 individuals who were enrolled in the UK collaborative HIV cohort study. And this took place during the years of 2004 to 2012. And what you're seeing here is liver-related mortality, which is substantially higher in those with HIV and Hep B co-infection, as well as HIV and hepatitis C co-infection, with the highest rates of liver mortality being amongst those with all three viral infections. And this is compared to relatively low liver-related mortality in the general HIV population. So let's talk about prevention of hepatitis B in people with HIV. So as you all know, vaccination is the key pillar of prevention. However, vaccine uptake remains suboptimal, even in people living with HIV, and rates of seroprotection are a lot lower in this population when compared to HIV negative healthy adults, where the seroprotection rate is about 90%. Hepatitis B vaccination is now universally recommended, not only for infants and children, but also for adults up to age 59 years of age, as well as recommended for adults 60 years of age and older who have specific risk factors for hepatitis B. And the OI guidelines and guidelines for people living with HIV have recommended hepatitis B vaccination for decades now. And the current guidelines recommend vaccinating individuals without chronic hepatitis B, who don't have immunity to hepatitis B or who don't have evidence of past exposure. So essentially folks who are hepatitis B surface antigen negative, core antibody negative, and surface antibody negative. But they also recommend vaccination of individuals with an isolated core antibody, meaning that they have only a positive core antibody in the absence of a positive surface antibody and are hepatitis B surface antigen negative. But how can we promote better seroprotection rates amongst people living with HIV? We know that they're kind of lag behind those in the general population. So one strategy can be providing a double dose of recombinant vaccination or recombinant vaccine. And one large systematic review that was published a couple of years ago in the Journal of Vaccine looked at standard dose versus double dose recombinant vaccine amongst people with HIV and found a higher serologic response rate, meaning a hepatitis B surface antibody greater than 10 among those who received a double dose versus just a single dose of recombinant vaccine. And so this is your Engerix vaccine and your Recombavax vaccine. And so the odds ratio for seroprotection was 1.76 at 4 to 6 weeks following vaccine completion and 2.28 at greater than 12 months following vaccine completion when looking at those who received the double dose versus those who received the single dose. However, across all the studies that were included in the systematic review, rates of seroprotection were still quite variable and suboptimal in many studies, ranging from anywhere from 47 to 88%. So another strategy that has emerged in the past several years has been to use the Heplisav-B vaccine. Heplisav-B is a relatively new Hep B vaccine that includes a cytidine phosphate guanosine adjuvant in combination with a recombinant HBV vaccine. And this is typically given at 0 and 1 months. The data for the use of this vaccine in people with HIV comes from the Beehive study, of which there are 2 kind of arms. In this arm B that you're seeing here on the screen, it was a multi-center open label trial that looked at 3 doses of Heplisav-B given at 0, 4, and 24 months in hepatitis B vaccine naive people with HIV. And individuals were eligible for this study if they had been on ART for greater than 56 days, if they had a CD4 count greater than 100, had an HIV RNA less than 1,000, and had no prior exposure to hepatitis B and no other immunocompromising conditions. And in total, this arm of the Beehive study enrolled 74 people with HIV. 46% were male. The median age was 47 years, and median CD4 count was in the 600s, and almost everyone was virally suppressed. 68 people were included in the primary analysis, the results of which you're seeing here in this graph. And what you can see is that 4 weeks after completing 3 doses of vaccine, 100% of individuals achieved seroprotection. And actually 83% of individuals had an anti-HBs greater than 1,000. So pretty robust seroprotection. But I think importantly, at week 24 here, before getting the third dose of vaccine, 98.5% of people with HIV had already achieved seroprotection, suggesting that 2 doses is probably sufficient in this group to achieve high rates of seroprotection. So looking at the vaccination schedule for people with HIV who are vaccine naive, the strategies that are recommended by the OI guidelines include either a double dose of Engerix, a double dose of Recombavax, and these are both given at 0, 1, and 6 months, or a single dose of Heplisav-B at 0 and 1 months, or for those individuals who are hepatitis A naive and hepatitis B naive, one could consider Twinrix at 0, 1, and 6 months. Although I've really started to kind of steer away from Twinrix and have been using Heplisav-B and Havrix, or the hepatitis A vaccine, separately due to higher rates of seroprotection with those individual vaccines in comparison to Twinrix. But what about vaccine non-responders? That's a huge issue in our population. So it is recommended that because of lower rates of seroprotection, people with HIV receive a anti-HBs level 4 to 8 weeks after completing the final dose of their vaccine series. And if this titer is greater than 10, great, they're immune to hepatitis B. But if the titer is less than 10, then that's when we would consider revaccinated individuals. And in certain individuals who have high risk for hepatitis B, you may also consider checking a surface antigen to see if they have chronic hepatitis B infection that wasn't previously identified, and that might be the reason for non-response. I will caution folks that you can get a falsely positive surface antigen near the time of vaccination. So this is something that you wouldn't want to check within like 1 month of vaccination. So some new data on strategies for kind of increasing seroprotection rates amongst previous vaccine non-responders came out at CROI this year, where the Part A of the Beehive study was presented. And so again, this is looking at Heplisav-B for hepatitis B vaccine non-responders. And this Part A included 561 people with HIV with prior non-response to a hepatitis B vaccination. And these individuals were randomized in a 1-to-1-to-1 fashion to receive either 2 doses of Heplisav-B at 0 and 4 weeks, or 3 doses of Heplisav-B at 0, 4, and 24 weeks, or 3 doses of Engerix at 0, 4, and 24 weeks. Key inclusion criteria included age 18 to 70 years. People had to be on ART for greater than 56 days prior to study entry. They had to have a CD4 count greater than 100. They had to have a viral load less than 1,000. And they also had to have a hemoglobin A1C of less than 9. So diabetes wasn't an exclusion criteria, but it had to be somewhat controlled. And then people couldn't have decompensated liver disease or CKD stage 4 or 5 or be on dialysis. And then individuals of childbearing potential had to agree to use contraception. So in this trial, the median age of participants was 46. About 36% were female, 40 to 45% Black across the different arms. Median CD4 count was in the 600s, and 94% had an HIV RNA less than 40. Seroprotection or a hepatitis B surface antigen greater than 10 was achieved faster in the Heplisav-B arm. And you can see that 99% of those who received 3 doses of Heplisav-B achieved seroprotection versus 93% of those who received 2 doses and 80% of those who received the 3-dose Engerix series. And then authors also commented that 96% of individuals in the 3-dose Heplisav-B arm versus 70% in the 2-dose Heplisav-B arm versus 63% in the Engerix arm achieved a hepatitis B surface antibody titer greater than 100. So I think more evidence to suggest that Heplisav-B is a very reasonable and effective option for prior vaccine non-responders. And I think that 2 doses is still what is recommended by the OI guidelines. I'm not sure if that's going to change based on these data, but I think 93% seroprotection is still quite good. Although in folks who maybe have a low CD4 count, who are not virally suppressed, but who are at high risk for hepatitis B infection, those may be individuals where you consider doing 3 doses instead of 2. So this figure here just outlines the recommendations or recommended strategies for vaccinations in people who previously didn't respond to a hepatitis B vaccine. So again, you can either use a double dose of Engerix or Recombavax, or use the single dose of Heplisav-B. And then they do list considerations for 4 doses of the Engerix and Recombavax given as double dose, as that may produce higher rates of seroprotection, particularly in vaccine non-responders. Talking briefly just about the management of isolated core antibody in people with HIV. So in the general population, there's no recommendation to vaccinate individuals with an isolated core antibody, but in people with HIV, the thought is that the anamnestic response that is mounted after kind of re-challenge with hepatitis B may not be as robust, and people may not actually have seroprotection against re-challenge with hepatitis B. And so the recommendation is to provide additional vaccination. So the strategy that's outlined in the OI guidelines is that for folks with isolated core antibody, they should be given 1 standard dose of the hepatitis B vaccine, and then check anti-HBs titers in 1 to 2 months. If the anti-HBs titer is greater than 100, and this is different than the marker for seroprotection that's used in other kind of vaccine strategies, then they can be considered immune to hepatitis B. But if the anti-HBs titer is less than 100, then the full hepatitis B vaccine series should be given, with the titer subsequently checked 1 to 2 months after the final dose. Before we move on to talking about other prevention strategies, I just wanted to comment on another hepatitis B vaccine that's relatively new called Prehevbrio. This is a triple antigen hepatitis B vaccine that's approved for use in adults. It has not been studied in people with HIV, but there is a randomized controlled trial comparing Prehevbrio to Engerix in hepatitis B vaccine naive adults without HIV. And in this study, seroprotection was achieved at 91.4% in the Prehevbrio arm versus 76.5% in the Engerix arm. And you can see that rates of seroprotection here were higher in the Prehevbrio arm across all different age groups when compared to the Engerix arm. Although there aren't any randomized controlled trials of Prehevbrio in people with HIV and no recommendations for its use in this population, I did want to highlight just one small prospective cohort study in Israel that evaluated immunogenicity of Prehevbrio in 31 people with HIV. 90% were male, and the median CD4 count was about 500. And in this small study, 84% achieved seroprotection, and there weren't any reports of serious adverse events. So shifting gears slightly to talk about hepatitis B chemoprophylaxis in people with HIV. So we don't have any randomized controlled trials of tenofovir for hepatitis B PrEP as we do for HIV, but observational data amongst MSM on tenofovir, both for HIV treatment and for HIV PrEP, suggest a protective effect. And we do know that antiviral therapy in pregnant persons with a high viral load of greater than 200,000 leads to lower rates of perinatal HBV transmission, suggesting that there is some treatment as prevention effect. So one of the larger observational studies that looked at this idea of antiviral therapy as chemoprophylaxis for hepatitis B came out of the multicenter AIDS cohort study. And this observational study looked at hepatitis B incidence in 2,000 375 MSM with and without HIV who were hepatitis B surface antigen and core antibody negative at baseline. Amongst these individuals, I will note that about 31% reported at least one dose of the hepatitis B vaccine at baseline. And what authors saw was that over 25,000 person years of follow-up, the hepatitis B incidence was about 14.9 per 1,000 person years in MSM with HIV and 7.8 per 1,000 person years in MSM without HIV, leading to an incident rate ratio of 1.9. And I think most importantly, the incident rate ratio for individuals on ART with a viral load less than 400 was 2.6 per 1,000 person years. And that's in comparison to individuals who were on ART but had a viral load greater than 400, which authors noted suggested non-adherence. And that incident rate ratio was 18.2 per 1,000 person years for hepatitis B acquisition. And there was also an incident rate ratio of 12.8 per 1,000 person years that was calculated in the pre-HAART era. So collectively just showing that the incident rate of incident hepatitis B infections was much lower in those individuals who were on suppressive ART. A similar study that came out of the Swiss HIV cohort included 1,716 individuals who were hepatitis B negative at baseline, and they followed them over time. There was 177 incident HBV infections over 10,682 person years of follow-up. And then they stratified incident HBV infections across receipt of different types of ART and found that collectively, incident infections were lower for persons on HBV active ART, including tenofovir, lamivudine, and emtricitabine. And what you're seeing here in this table is just the hazard ratio for HBV acquisition, which was lower across all different types of HBV active ART and was about 1 or slightly over 1 in all other non-HBV active ART. And the only thing that I'll point out here is that the confidence intervals were quite large for the TDF only arm because they just had few people who were only on TDF and no other HBV active ART. But what you can see is very low hazard ratios for incident HBV infection in people receiving TDF and 3TC or TDF and FTC with confidence intervals that are well below 1. So talking about HBV treatment in people with HIV, all major guideline committees, including AASLD, the OI guidelines, the European guidelines, the APASL, which is the Asian Pacific guidelines, all guidelines recommend initiation of HBV active antiviral therapy in folks with co-infection, regardless of CD4 count or hepatitis B viral cofactors. And really the goals here are to 1, reduce necroinflammation and HBV DNA replication, and 2, avert or delay development of cirrhosis, end-stage liver disease, and liver cancer. So although there are 6 oral antiviral agents and 2 formulations of interferon alpha that have been approved at one point for hepatitis B, we really only use 3 different antiviral agents, and those include TDF, TAF, and entecavir. And that's because of the high potency against HBV of these agents and the high barrier to resistance. While lamivudine was used frequently in the past, this is no longer recommended as monotherapy due to high rates of resistance, which is estimated to be about 70% after 5 years of therapy. And then entecavir also shouldn't be used as monotherapy for hepatitis B in individuals with HIV who are not otherwise on fully suppressive ART, as it does have some activity against HIV and can produce an M184V mutation. So for our patients with HIV, they're usually on either TAF or TDF. And one question is, which of those do you choose? There was a phase 3 double-blind RCT that aimed to answer this question, and it compared TAF-FTC bictegravir to TDF-FTC dolutegravir in persons with HIV and hepatitis B co-infection. And this was done at 46 outpatient centers across 10 different countries. Eligibility included you had to be treatment naive and greater than 18 years of age. And so people had to have an HIV RNA of 500 or greater and a HBV DNA of 2000 or greater. And they were randomized in a one-to-one fashion to either receive this TAF-FTC bictegravir or TDF-FTC dolutegravir. And then results were stratified by CD4 count, hepatitis B E antigen status, and hepatitis B DNA. And in total, 243 persons initiated treatment. Greater than 90% were men. Most of the enrolling sites were in Asia, and then the median age was 32. And while HIV virologic outcomes were similar across both groups, with HIV RNA of less than 50 in 95% of individuals in the TAF-FTC bictegravir arm at 48 weeks, and HIV RNA less than 50 and 91% in the TDF-FTC dolutegravir arm at 48 weeks, there were some differences in the hepatitis B outcomes. So at 48 weeks, hepatitis B DNA of less than 29 was found in 63% of individuals in the TAF-FTC bictegravir arm versus only 43% of individuals in the TDF-FTC dolutegravir arm. And then hepatitis B surface antigen seroconversion, so loss of surface antigen and gain of surface antibody, was found in 8% of the TAF-FTC bictegravir arm and 3% of the TDF-FTC dolutegravir arm. So these kind of 48-week data after they were presented suggested that maybe there was some advantage to using TAF over TDF for folks with hepatitis B. Although I'll say that the 96-week results are a little bit more attenuated and don't show as great of a difference. So when they extended these data out to 96 weeks, viral suppression for hepatitis B was seen in 75% of the TAF-FTC bictegravir arm versus 70% of the TDF-FTC dolutegravir arm. And then hep B seroconversion, surface antigen seroconversion was seen in 9% of the TAF-FTC bictegravir arm and 7% of the TDF-FTC dolutegravir arm. So not as great of a difference there. And I will mention that viral suppression rates at 96 weeks for HIV were similar in both arms. So what about drug resistance? I know this is something we think about a lot in HIV. And what should we be thinking about in hepatitis B? So as I've already mentioned, resistance to 3TC and FTC is common, and it occurs in approximately 20% of individuals per year who are on 3TC monotherapy. 3TC resistance can lead to partial entecavir resistance. So entecavir should either be avoided or dosed at a higher 1 milligram daily dose in folks who are 3TC experienced. Tenofovir resistance is really rare in hepatitis B, although testing is available, but that's rarely the cause of persistently elevated viral levels. And I think it's important to remember that declines in hepatitis B DNA can be much slower in hepatitis B than in HIV. So we're very accustomed to see viral levels fall to undetectable in a matter of weeks to months in HIV. But this can take several years, actually, for folks with hepatitis B, and particularly for folks who have a really high viral level at baseline. So oftentimes we're seeing viral levels in the hundreds of millions or a billion, and that can take quite a bit of time for that to fall down to an undetectable level. And although improved virologic response has been seen with the addition of entecavir to TDF, so adding entecavir to somebody who's on a fully suppressive regimen that includes TDF, it's not clear that that is necessary in most cases, and that's not kind of general practice. And then I wanted to just mention briefly too about stopping HBV active ART. I think this is something that is coming up more and more in this era of injectable ART and tenofovir sparing AIT. And really, this should be avoided. Don't do it in people with HBV. as this can lead to elevated LFTs and hepatitis flares. And the data you're seeing here on the right side of your screen is a retrospective analysis of the Swiss HIV cohort study that included 109 individuals with co-infection who were taken off HBV active therapy. And LFT elevations occurred in almost 30% of these individuals. 3 patients presented with fulminant hepatitis, and there was 1 death. And so the OI guidelines say that if anti-HBV therapy must be discontinued, then monitoring of LFTs at a very closely should be performed, ideally every 6 weeks for about 3 months and every 3 to 6 months thereafter. But I think the main point is just that if you have somebody with HBV and HIV co-infection, it's really important that they not be taken off of HBV active ART. And then what about HBV iris? So this is something that is not super common, but the risk is highest amongst those who initiate on non-HBV active ART and typically occurs within the first 12 weeks or so of therapy. This can be a really challenging entity to distinguish between drug-induced liver injury or other causes of hepatitis in iris. But if you're suspecting hepatitis B iris, consider checking LFTs Q6 to 12 weeks after introduction of ART, and then you can move to a more standard kind of Q6 months thereafter. And then typically in these settings, the HBV active ART is continued unless LFTs are like 10 times the upper limit of normal or there's fulminant liver disease. And there's really insufficient data to suggest for or against the use of steroids, although generally steroids are avoided in people with HBV because it can suppress kind of the body's response to the infection and lead to flares. Then what about screening for hepatitis delta or HDV in our patients? So as many of you know, hepatitis D is a small RNA virus that does require the hepatitis B surface antigen for replication. And the only approved treatment for HDV is interferon therapy. But HDV and HBV co-infection can lead to faster progression of fibrosis and leads to an increased risk for hepatocellular carcinoma. And the estimated prevalence amongst hepatitis B surface antigen positive individuals is about 4.5%, with higher risk amongst people who inject drugs and persons with hepatitis C or HIV co-infection. And so, you know, the guidelines really kind of differ depending on which one you're looking at in terms of how we should be screening for hepatitis D. So the European and Asian Pacific guidelines recommend screening in all individuals with a positive hepatitis B surface antigen, so essentially all individuals with chronic hepatitis B, whereas the AASLD guidelines recommend screening individuals with certain risk factors, including those from high endemic areas, which you see here in the map in the kind of red and orange. They recommend screening in people who inject drugs, MSM, individuals with multiple sexual partners, those living with HIV, hepatitis C, and then those who have elevated LFTs in the setting of low hepatitis B DNA. So I think really guidelines would say that we should be screening everyone with HIV and hepatitis B for hepatitis D virus. I will say that I probably do less screening than I should, just because oftentimes, you know, if you can suppress the hepatitis B virus with antiviral therapy alone, you're going to also suppress kind of the hepatitis D replication. And, you know, it's, I think, a big decision to give somebody interferon. But I think the guideline answer is we should be screening for this more than I think we are. And then finally, for hepatitis B, I just wanted to comment on HCC screening because I think this is something that's really important for us to remember in our practice and can oftentimes get lost. And I think we are doing a disservice to our patients if we aren't appropriately screening them for liver cancer. So even in the absence of cirrhosis, hepatitis B can lead to liver cancer. It's oncogenic in and of itself. And we know that persons with co-infection with HIV and hepatitis B are at increased risk of developing liver cancer and can develop it at an earlier age. And so the table here on the right is listing out the guidelines for HCC screening based on specific risk factors. And so for kind of all comers with hepatitis B, there are specific guidance on who to screen for liver cancer. But I will say that many experts would recommend screening all persons with co-infection starting at age 40. And that's what I have done in my practice, is just screen all of my patients living with HIV and hepatitis B at least at age 40. If they have other risk factors like hepatitis D, or if they have a family history of HCC, I will start earlier. And then also typically would start earlier in persons from Africa due to higher risk of HCC in that population. And the screening is done with both an ultrasound and AFP every 6 months. And this is a slight update from before, where the guidelines used to recommend ultrasound plus minus AFP every 6 months. The 2023 update has now included AFP in their recommendations every 6 months. So I'd like to shift gears now and talk about hepatitis C and HIV co-infection. So as many of you know, co-infection with hepatitis C and HIV is common owing to shared risk factors, and all persons with HIV should be screened for hepatitis C. Amongst persons living with HIV in the US, there's an estimated 15 to 30% who have hepatitis C co-infection. And then in the US, approximately 5% of persons with chronic hepatitis C also have HIV. And what you're seeing in the graph on the right is data from the 2023 CDC progress report on viral hepatitis that unfortunately shows that estimated new hepatitis C infections continue to increase annually, and that the US is really nowhere near our annual targets for new hepatitis C infections that's been set out by the elimination initiatives for Hep C. And that's shown here in the orange line. That's where we really should be, and the blue lines are where we're at. And so while injection drug use is the most common risk factor across the board for hepatitis C infection, there's also a higher incidence of hepatitis C amongst specifically HIV positive MSM through sexual transmission. And in a systematic review and meta-analysis evaluating hepatitis C prevalence and incidence amongst MSM, the pooled Hep C prevalence in MSM was 3.4%, but it was 6.3% amongst HIV positive MSM and 1.5% amongst HIV negative MSM. And when looking at HIV negative MSM that were on or not on PrEP, pooled HCV incidence was considerably higher in individuals on PrEP when compared to individuals not on PrEP. And this is felt to be due to increased sexual risk for HCV acquisition. Similar to hepatitis B, co-infection with hepatitis C and HIV can accelerate the progression of hepatic fibrosis and lead to earlier development of cirrhosis. And cirrhosis has actually been observed to occur anywhere between 12 to 16 years earlier in persons with HIV and Hep C co-infection versus hepatitis C alone. And then up to about 80 to 90% of liver-related deaths in persons with HIV are attributable to hepatitis C. So this is a huge cause for morbidity and mortality in our population. As hopefully everyone knows, all adults should be screened for hepatitis C regardless of risk factors. And this is a recommendation set out by the US Preventative Services Task Force, as well as AASLD and IDSA and CDC. And one-time Hep C testing is also recommended for persons of any age, so persons less than 18 years, for example, if they have recognized risk factors. Routine screening is now recommended in all pregnancies, and then routine periodic testing should be performed for folks with ongoing risk factors. And that includes individuals who are using and sharing injection drug equipment, as well as for MSM engaging in condomless sex with multiple partners. And I would say for other individuals engaging in receptive anal intercourse as well, not just MSM. Prevention of hepatitis C, we don't have vaccination, of course, and there's not really the same role for potential chemoprophylaxis, but really prevention messages should focus on harm reduction strategies. So for folks who are using injection drugs, discussing getting all of their injection equipment at syringe service programs so that they can use clean equipment every time and don't have to share or reuse equipment. Talking about medications for opioid use disorder, including Suboxone and methadone, which can reduce the incidence of or reduce injection frequency and potentially help folks get off opioids altogether. And then discussing safer sex practices, using barrier protection, and educating folks about sexual transmission are really kind of the mainstays of our prevention messages. So although folks with HIV have historically been considered a hard to treat population during the interferon era of Hep C treatment, data from multiple studies now indicate that SVR12 rates, which is our cure rates, are comparable amongst people with HCV monoinfection and HIV HCV co-infection, specifically in this modern direct-acting antiviral era. And this is really regardless of the treatment that is used. And so you'll see here on this slide that glecaprevir pibrentasvir and sofosbuvir velpatasvir, which are the two most common DAA regimens, have very similar cure rates in folks with co-infection and monoinfection. And because the direct-acting antivirals have really revolutionized the treatment of hepatitis C and allowed for shorter, safer, and more effective treatment, guidelines for Hep C treatment have really been simplified and streamlined. And the AASLD and IDSA has come out with simplified guidance for Hep C treatment that applies to persons with HIV as well. And so who's eligible for this simplified treatment approach? It's really adults with chronic Hep C infection, regardless of genotype, who don't have decompensated cirrhosis and who are Hep C treatment naive. And then folks who would not be eligible and who may require more kind of workup ahead of time would be folks with prior treatment, decompensated cirrhosis, co-infection with hepatitis B. And that's really because folks with chronic hepatitis B are at risk for Hep B flares and reactivation during Hep C treatment. Folks who are currently pregnant, folks with known or suspected HCC, history of liver transplantation, and patients with compensated cirrhosis and end-stage renal disease. So most individuals can be treated with a simplified approach. And I would advocate that if you're not somebody who treats a lot of hepatitis C or not comfortable with hepatitis C treatment, for folks who may fall into this red box below, and specifically for folks with decompensated cirrhosis, that may be somebody who you would refer to a specialist. So really what's involved with the pre-treatment assessment for folks in the simplified algorithm, the AASLD and IDSA guidance recommends calculating a FIB4, assessing for cirrhosis, doing a med rec, assessing for potential drug-drug interactions, educating the patient on medication administration and adherence, and then pre-treatment laboratory assessment. So pretty standard stuff. The FIB4 is a calculator that uses age, AST, platelet count, and ALT. And you can easily find this on the hepatitis C or hepatitis B online sites that are put out by the University of Washington. And then there are other methods for screening for liver fibrosis. And one common one that is used is the FibroScan or transient elastography. And this is just a picture of it here in case you've not seen the machine. Essentially, FibroScan emits kind of a shear wave through the liver, and the velocity corresponds with liver stiffness. And this can help us understand how much scarring or fibrosis is in the liver, and can be an easy and very effective and accurate way to screen for fibrosis pre-treatment. Although I want to acknowledge that not everybody has access to a FibroScan, and I don't think that in folks who have kind of clearly low levels of fibrosis based on FIB4 or APRI, this is not necessarily needed prior to treatment and shouldn't be a barrier. But it can be particularly helpful in cases where you might have discordant results on other non-invasive testing, or maybe the FIB4 is giving you a higher score, and you think, well, maybe the high AST and ALT from in this young person with sort of, active hepatitis is producing a higher score than normal. I really don't think this individual has cirrhosis. That may be a nice time to use FibroScan or transient elastography. So in terms of assessing for cirrhosis, I mean, this is really just a clinical diagnosis most of the time. You can use non-invasive markers like FIB4, APRI, FibroSure, and then there's imaging studies like FibroScan. And then, of course, the real gold standard is liver biopsy, but that's not done as much anymore. And then exam clues are all the ones we learn in med school: spider angiomata, enlarged spleen, ascites, jaundice, scleral icterus. And then on the labs, I use clues like thrombocytopenia, elevated T-bili, elevated ALK phos, and then an AST that's greater than ALT, which is more commonly seen in cirrhosis. And then, of course, seeing splenomegaly or recanalized umbilical vein should be clues on imaging. When assessing for drug-drug interactions, I just want to highlight the University of Liverpool drug-drug interaction checker. It's like the same one essentially as you use for HIV, but it's just the hepatitis C one, and the URL is listed down here below. And this is what I use to screen for drug-drug interactions. In terms of pretreatment laboratory assessment, it's really quite streamlined. So a complete blood count, hepatic function panel, and glomerular filtration rate should be obtained within 6 months of treatment initiation for patients without cirrhosis, and within 3 months of treatment initiation for patients with cirrhosis. Any time prior to treatment, you need to have an HCV RNA, screen for HIV, and screen for hepatitis B surface antigen. And then before treatment, in persons who may become pregnant, I like to screen for pregnancy, as none of the DAAs are currently approved for use in pregnancy. Oops, apologies. So the two drugs that we're most commonly using and that are recommended as part of the simplified treatment algorithm include glecaprevir pibrentasvir, which is a pangenotypic NS3/4A protease inhibitor and NS5A inhibitor combo pill, and then sofosbuvir velpatasvir, which is a pangenotypic NS5A, NS5B inhibitor. The differences, between these drugs is that the glecaprevir pibrentasvir is given as 3 tablets once daily, and that's for 8 weeks, whereas sofosbuvir velpatasvir is given as 1 tablet daily for 12 weeks. Glecaprevir pibrentasvir should be taken with food, whereas sofosbuvir velpatasvir does not have a food requirement. Sofosbuvir velpatasvir can be used in folks with decompensated cirrhosis, where glecaprevir pibrentasvir should be avoided in decompensated cirrhosis. Both can be given in patients with renal impairment. And then there are some notable drug-drug interactions, the most common of which for sofosbuvir velpatasvir include proton pump inhibitors, and then for glecaprevir pibrentasvir, statins, ethinyl estradiol, and then HIV protease inhibitors and select NNRTIs. So specific to HIV, this is a table from the IDSA AASLD guidance on Hep C treatment. And you can see here that for most of the frontline ART regimens that we use, there's no significant drug-drug interactions with sofosbuvir velpatasvir or with glecaprevir pibrentasvir. Where we run into trouble is with some of the older NNRTIs, but I don't think we really have any folks on efavirenz or etravirine anymore, so that's not a big concern. And then protease inhibitors, which because glecaprevir pibrentasvir has a protease inhibitor in it, it should not be used with other HIV protease inhibitors, but can be used with integrase inhibitors and our frontline NRTIs. So just to summarize the recommendations for Hep C treatment in people with HIV, for those who are treatment naive without cirrhosis, they can use either glecaprevir pibrentasvir for 8 weeks or sofosbuvir velpatasvir for 12 weeks, again, depending on their baseline ART regimen. And then for treatment naive individuals with compensated cirrhosis, who are genotypes 1, 2, and 4 through 6. You can use either glecaprevir-pifrentasvir or sofosbuvir-velpatasvir. And then for folks who have compensated cirrhosis and genotype 3, you do need to, if you want to use sofosbuvir-velpatasvir, you do need to check for resistance. NS5A RAS testing or resistance-associated substitution testing is recommended in these individuals prior to use. And then I just wanted to highlight here that although the 12-week duration of glecaprevir-pifrentasvir is better studied for folks with HIV and compensated cirrhosis, real-world data does suggest that 8-week duration is okay. And that's typically what I have seen in practice. Just briefly about laboratory monitoring, most individuals don't need on-treatment laboratory monitoring. There's a couple of key sort of messages that should be relayed to patients, and those who are taking diabetes medications, for example, should just monitor for hypoglycemia. Patients on warfarin should have INR monitoring, of course, to evaluate for subtherapeutic anticoagulation levels. And then in patients with compensated cirrhosis, some providers may order liver function testing to monitor for liver injury during treatment, and that's typically standard of care. And then some experts would also monitor LFTs on treatment in patients who have isolated core antibody, just due to the very, very low risk of reactivation of hepatitis B while on HCV treatment. And then, of course, all patients that undergo repeat hep C RNA testing and liver function testing 12 weeks post-treatment to assess for cure. And I will say that this kind of minimal monitoring approach has been studied, and one kind of key study evaluating very minimal monitoring during treatment was the MINMON study, which was a phase 4 open label single arm trial that examined safety and efficacy of a minimal monitoring approach to hep C, using 12 weeks of sofosbuvir-velpatasvir in treatment naive individuals, including persons with HIV co-infection. And so what they did is that they didn't do any genotypes. They stratified cirrhosis based on FIB4 count, and then they actually provided all pills at the time of entry, and just did phone follow-up at 4 weeks and then 22 weeks, and then obtained an SVR 12 level 12 weeks after treatment completion. And SVR 12 rates were excellent across all of the arms here, including the HCV mono-infected and HIV HCV co-infected individuals, where you saw SVR 12 rates of 95%, even with very minimal monitoring while on treatment. I just want to briefly talk about the impact of treatment interruptions on SVR 12, because I think this is something that comes up commonly in clinical practice. So the SIMPLIFY study was an international open label single arm study of 12 weeks of sofosbuvir-velpatasvir in persons with recent injection drug use. And although 97% completed treatment, 88% of individuals missed at least one dose, and 32% of individuals were considered kind of non-adherent based on less than 90% adherence. And you can actually see this over here in this figure, where the green, each like row is an individual, and the green indicates taking their sofosbuvir-velpatasvir, and the yellow indicates missed doses. And so the longest episodes of non-adherence were typically 1 to 2 days, but in 17% of people were 3 to 6 days, and in 11% of people were greater than 7 days. And despite episodes of non-adherence, SVR12 was achieved in 94% of both quote unquote adherent and non-adherent individuals, with adherence stratified by taking either less than 90% of your pills or greater than 90% of your pills. So I think data just to suggest that these treatments are actually relatively forgiving. Obviously, the messages should be to take your medication every day. But even in the absence of perfect adherence, a lot of people achieve SVR12. And just another study to kind of highlight that was this retrospective review of patients registered in a web-based regional Italian HCV treatment database. The treatments that were used included sofosbuvir-ledipasvir, sofosbuvir-decladasvir, and sofosbuvir-velpatasvir. 67% of these individuals had cirrhosis, and the planned treatment duration was 12 weeks for about 65% of individuals, 8 weeks for 7% of individuals, and 12 weeks for the rest. And what you can see is that for folks without cirrhosis here, if they received 4+ weeks of treatment, almost all achieved an SVR12, and then receiving 8+ weeks of treatment for those with cirrhosis was associated with very high rates of SVR12. I will just mention that treatment interruption recommendations are listed in the IDSA AASLD guidance page, and so you can look those up if you do have an individual who is experiencing a treatment interruption. And with that, I am just about out of time, so I am going to stop here and give time for a couple of questions. And thank you so much for your attention today, getting through all of this material.
Thank you so much, Maria. That was really comprehensive and outstanding. There are a couple of questions in the Q&A. How often do you recommend hepatitis D screening?
Yeah, it's a great question. I think, the guidelines would say that we should be doing it in all of our patients with HIV. And then the AASLD guidance would also say that we should be doing it in folks with risk factors like people who inject drugs and folks from higher endemic areas. I'll admit that I don't do it as frequently as that, although I probably should. But the reason for sometimes my hesitation is that I'm not sure it's necessarily going to change what I do. If people are responding appropriately to hepatitis B antiviral therapy, they're virally suppressed, their LFTs are suppressed. I think there's going to be very little role for actually treating hepatitis delta with interferon. Now, it may, in somebody who's younger, it may cause you to screen for HCC sooner. So oftentimes I will screen based on if I think it will change anything about what I'll do clinically. But the guideline answer is we should be screening everybody with HIV.
Great, thank you. And then there's a question about patients with isolated Hep B core and consideration of switch to a non-tenofovir containing regimen. Would you avoid such a switch in practice or monitor for reactivation after a switch?
Yeah, that's a great question. I would ideally vaccinate them first. As I had a slide on earlier, there are recommendations for vaccinating individuals who have isolated core and are folks living with HIV. So probably my approach would be to repeat the vaccination, document seroprotection, and then I think it would be fine to switch to a non HBV ART regimen.
Great. There's one more question for individuals who seroconvert from surface antigen. Is there ever a point where you feel that the Hep B is declared cured?
Yeah, so seroconversion is very rare, but that's kind of the holy grail. So this loss of surface antigen and gain of surface antibody would be, considered a durable cure, although that is very rare in individuals. And so, that is not something we see often in practice, but can happen where you have that loss of surface antigen and gain of surface antibody, indicating sort of immune response to the virus.
Great. And there's a question in the chat about vaccinating isolated Hep B core individuals with HIV. Do you do everyone with HIV or only those with, is it for everyone regardless of HIV or other risk factors, or just those with those risk factors?
Yeah, no, great question. So that is a distinction made just specifically for folks with HIV. So everybody with HIV, kind of regardless of risk factors for Hep B, are recommended to be vaccinated if they have an isolated core antibody. Whereas individuals who are not HIV positive and have a positive core antibody, like an isolated core antibody, are not recommended to have vaccination, if that makes sense. So positive isolated core and living with HIV, vaccinate regardless of other risk factors. Not living with HIV and positive core, no need to vaccinate.
Thank you so much. We're at time, but thank you so much again, Maria, for that outstanding talk. And thanks everyone for joining. Have a great rest of the day.
Great. Thank you guys.